now that these have been going on. And the idea was to get together physicians from US and from Pakistan to share experiences and challenges and questions and address any concerns and comments on a platform. It started initially as a daily webinar that went on for 30 days. And then when Ramadan started, we went on to weekend webinars with 2 days a week. And now as people are starting to get busy with the clinical care and practice, we have gone down to at least one webinar a week on Sunday. But as we get requests to do some special topic webinars, then we will probably add some Saturdays. So we are working on some special topic webinars on psychosocial issues and mental health of primary care providers and healthcare providers, frontline workers. We're working on a special issue on nursing challenges related to COVID-19 with the team at Khan and team in Qatar. In Saudi Arabia, and that's a wonderful project we're working on that will be coming out soon. And then we have some other things that are on the back burner. But anyway, so I welcome everyone. I welcome the panelists, speaker, and attendees to this webinar. This webinar is being video recorded, and it will have a rerun later on through our partners and collaborators in Pakistan, PharmEvo, who will rerun this webinar for another audience of primary care physicians who could not attend. And then this will be hosted on YouTube where people who are registered for the webinars but could not attend the live one can go and watch it. We are working on getting CME credits for it, including from our partners in Rawalpindi Medical University and also from APPNA itself. So please be on the lookout for that, for some certificates if you have attended it. That's the importance of signing in with your own email address and the specific link that gets to you with registration, so that we can keep track of who attended which webinar, so we can send them the certificate of attendance. So the webinar will go similar to what we have done in the past. What we typically do is to spend the first half hour on a general overview and presentation by the speaker, and use the second half hour for our discussions and Q&A from the panelists. And we usually go over time, and we're okay in staying around as long as people have time to talk about questions that still need to be addressed. Please ask your questions in the Q&A box. That's the best way of asking the question for me to keep track of what's being asked. You could also use the chat function if you're not having access to the Q&A box, and that's fine. We'll try to keep a track of that, but that may become harder. You can also post your question on the WhatsApp group for webinar, and then we have collected questions over the last week for anything related to this webinar that you posted on the webinar platform that we will be also using. And then if we have time, we will try to give you the microphone as an attendee. You can raise your hand and we will try to come to you, but we will try to ask the questions that have been asked in the Q&A box first before we are able to give you the microphone, and also based on time permission. Very good. So I think we are 5 minutes after 8, and that's our right time to start with the webinar. I'm going to start with the introduction to speaker, and then the speaker will give its overview. And then before we start the Q&A, I will invite the panelists to introduce themselves one by one. I am really pleased and delighted for the topic of this webinar today about challenges faced by the primary care physician in COVID-19 and their role. This has been a question that started from the very get-go 2 months ago, as primary care physicians were struggling to provide care to their patients for the chronic illnesses unrelated to COVID-19 in the environment of social distancing and preventing the spread of COVID-19. So that was a big challenge. And I know that early on we were trying to figure out and struggle. In US, we had the liberty of just canceling our clinics and going to telehealth, but I know that's not something that's possible in most of the world, and that remained a challenge and concern. And now we're seeing physicians getting sick and even having deaths while getting infected in their line of duty. This has become even more and more pertinent and an important topic. So it gives me great pleasure to have Dr. Abdul Jalil Khan, a consultant family physician and assistant professor in the Khyber Medical University for the Family Medicine Department, here to present this topic. There are many things I can say about Jalil, about his energy, about his passion and enthusiasm. But the most striking thing to me is that when I heard from him and from others that he was talking while he was practicing UK about changing the family medicine field in Pakistan, and people said, well, if you're really serious about making a change, why don't you just move to Pakistan? And that's usually just used as a threat to someone who's trying to make some recommendation, suggestion. But Jalil took it seriously. He gave up his job in his budding career in UK, resigned and moved to Pakistan and said, okay, I will put my money where my words are, and I will do what I said should be done. And that is just so hugely impressive. And I have huge regards and respect for Jalil Khan for doing that. And we are extremely supportive of all his endeavors and want to see him succeed in his future career. With that, let me invite Jalil Khan to take on the stage and introduce any more things he wants to tell him about himself, and then proceed with the talk for the day. Please, Jalil, take your stage.
Bismillahirrahmanirrahim. Assalamu
alaikum. Walaikum salam.
Thank you very much, Dr. Danish, for that nice introduction. But I'm sure most of us know that we all are here because we want to bring a change in our homeland, Pakistan. And that is to improve the health system. So that is the main aim of all of us, and that's why we are here. So all the work we all do, initially everybody used to say that everybody wants to help in Pakistan, but we need to have an integrated approach, where I strongly agree. But when I heard about this share of Faraz, so that completely changed my way of thinking. So as I said, we all are here to do something, and everybody is trying to ignite the candle, whatever he can or he could do. So thank you to everyone. So, and inshallah, a day will come, that's why we all are here together, and a day will come that we will bring that change we all want. So thank you very much. I will start with the topic because, as I said, like, you know, a lot of panelists are here and people would love to listen to them rather than just me. So I'm not sure if I will be able to share the screen, or I think I can, isn't it? Sorry, can you?
Yep, Jalil, we can see your screen. Thank you.
Okay, thank you very much. So, as you mentioned, Danish, that the talk here today is quite important, and it is about, you know, the challenges faced by the primary care physician and their role in this COVID pandemic. So I give it the title of Making the Impossible Possible. I'm sure we all talk about the ICU people and all the frontline warriors who are trying to help people. But the primary care physician, as we all say, is first in and last out. So the primary care physician are the main frontliner here. So before starting, I would like to thank you, all of you, especially the panelists, Dr. Unab, Dr. Hisham, Professor Zia, and Dr. Tariq Aziz for their valuable time, and also grateful to you and Shahid Bhai for giving us this opportunity. To start with, I was thinking, you know, that whose picture shall we put, like, you know, because we would like to pay tribute to all the heroes. But every day, unfortunately, we are having few more martyrs. And even, you know, I'm finding it having difficult to have words for it. Even yesterday, I had one of the GPs died just kind of less than a mile radius away from me. And today, one pediatrician in Nowshera and one pathologist in police services hospital, whom I've been in contact for the last few days because I was trying to do some IPC, infection prevention control training. So this is the reason, as a primary care physician, I took the lead, and I'm also now supporting WHO as a consultant, infection prevention control, because I realized that a lot of our friends are dying because it's not just lack of PPE, because it's lack of the standard precaution in our health system, which is infection prevention control. So we will talk about the challenges which they come across. So that's why I kept the title as Watan Ki Mitti Gawah Rehna. So it's so many of them, you know, all these heroes, you know, who have given their life for the cause. So may Allah put them in the highest rank of Jannah. and give patients to the family. So before I start, I'm sure all of you know, but if we just quickly elaborate, what is the role of primary care physician and what is the role of a GP or family physician, whatever you call. So if we look at the points which is normally mentioned by the Royal College, so you will figure out by yourself that what our role as a GP is during this pandemic, or what we call primary care physician in Pakistan, because in Pakistan there's two sectors, private GPs and also the GPs who are working or the medical officer working in primary healthcare units. So if we look at them, so provides personal, primary and continuing medical care to individuals and families, makes an initial decision on every problem presented, consults with specialists when appropriate, intervenes to promote health, clinical decisions influenced by prior probability of diseases, and has an advocacy role for the patient, and then specific responsibility for the health of community. So if you look at all these roles and then you look at the pandemic, so you tell me then who got the biggest responsibility. So I'm not denying the fact that specialists are doing the jobs, but the primary care physician are the frontline warriors. So here in COVID, their role is what? Is both curative and preventive. Plus, I'm sure the state in Pakistan is not different from any other country. People are still having the conspiracy theories and they're listening to them. Social media is not helping and they are getting information which is not factual. So we have to gain the trust of the public. We have to do health promotion. We have to do community orientation. And last but not the least, we have to ensure that health by provision of essential health services. I'm sure most of you know, there were temporary closure of clinics. The hospital are shut for non-COVID diseases. So where are all these people going to go? Even people raising questions that where are people now not dying from, why people are not dying from strokes anymore? Why people are not dying from ischemic heart disease anymore? They are dying. The problem is because there's not been reporting, people are dying at home. I'm sure most of you recently watched the news, when ED was raised an alarm that 300 dead bodies they collected in Karachi only. Yeah. So as we said, the task which have been given to us. So if we have been assigned the mountain to show others it can be moved, so that's the task for us. So that's why the responsibility came to us. The next two pictures are basically photographs by Dr. Sajjad, again a GP from Cardiff. And that's his view. If you look at this picture, this is what we call specialist view. So specialist is focusing on this corridor, which is, or on this highway, which is heading toward the mountain, whether it's just a mountain or whether it's something more happening there. So if you look at it, it's the same picture, and I will show you the next picture by Sajjad. So this is the view by the specialist. And the next picture is the view of the same area by a trained journalist or a primary care physician or a family physician or a GP from UK. So can you see the difference? It's the same lake, the same mountain, the same highway, but that GP have more holistic approach. He's got a more broader view. He has to see, what else I need to do apart from just focusing on that illness the patient has got. I'm not just treating that COVID patient. I'm not just treating his symptoms of respiratory problems, but I have to look after the 12 people he has to feed. I have to look after the other people he already could have infected or he may have infected. I have to look at the stigma which this patient may take home, if he doesn't get treated. So that's the difference. And I'm sure most of you know that family doctors are called gatekeepers, which is first in and last out. So our job now is what? To convince people to go to hospital because they're feeling alone during the difficult decision, and so are we. And there is a risk of burnout because in hospital, it's very easy. Yesterday, we referred a patient to Islamabad. Most of the hospitals in Islamabad, they are already overcrowded and there are no space available, no beds available. So what they said was, we don't take any more emergencies. But as primary care physician, as GPs, as family physician, what would we say to them? Are we going to say the same, that we are overcrowded? Sorry, we are closed. We can't do that. So obviously you have to provide that care. So now if we come to the top 5 challenges, I'm not going to go into too much details, I will just put the top 5 challenges with me as a GP is facing, which Unab and Hisham and the rest of our colleagues in US might be facing. And the panelists will be then able to describe whether these are the same challenges they are facing as well, or the solution which I am trying to mention, whether that's the same solution they're thinking as well, or they might have better expert opinion than me. So if we go to the challenges, the first challenge is change in practice style. Not sure whether you can see that or not. The next slide. Can you all see that? Yeah. So change in practice style, and then managing risk and uncertainty, sustainability, person safety, working in isolation, risk of burnout. So is it something you all familiar with? That is something which we all are facing at the moment. I'm sure most of us do. Okay, so when you talk about changing the practice style, so if things don't go the right way, change the way, not your goal. So our goal is still to treat the patient. So we're not going to change our goal, we're just going to change our way. So if you look at it, a lot of our GPs are quite senior GPs who are not used to IT system, who are IT naive. And what started was temporary closure to moving it online or treating patient from far away. We are using telehealth, we are using telemedicine. And then the problem we are getting is adaptation to the technology. We develop a very good telemedicine system in our university, but then we realize the internet server is not that good. People who are calling us from far-flung areas, their service is not that good. So it's the adaptation of technology from both patient side and the doctor element. Remote prescription, we are not used to it. If there is a mistake, who's going to be responsible for it? Is the patient getting the information right or not? The other important thing is unable to examine patient. And if all these issues are there, the problem will going to be the patient satisfaction. I'm sure Hina and other people who are listening to me, they are already trying to provide better service they can through telemedicine services. But are we overcoming if we're not able to examine the patient? Are we still feeling that much confident that we are treating them right or not? So here come then managing risk and uncertainty. So we are dealing with uncertainty. The most important of that one is patients is still, unfortunately, especially in Pakistan, in a denial state. I get calls from 100 patients in a month. For what? Doctor, I've got a sore throat, but you know, I got this allergy, you know, so it doesn't look like COVID. What should I do? So patient is still in denial state. A lot of people still think like, you know, it's just a myth. It's a conspiracy. So obviously, first of all, you need to admit that there is a problem. Unless you admit there's a problem, you're not going to look for a solution. And then lack of information regarding patient condition. In Pakistan especially, we don't have electronic medical records. We don't have System 1. We don't have MSweb. We have no luxury to assess patient previous blood results. So that's going to be an issue we're all going to get. The top of that is patient hiding their symptoms. I practice as diabetologist, and patients do come to me with uncontrolled blood sugar, and they've denied information to the triage. But later on, you find out that the patient also got upper respiratory tract symptoms. So the question is, what are you going to do then? Have you done all the protection? No. So we're not going to be able to fully assess patient when we're doing remote consultation. So sometimes we have to call the patient. So there is infection risk. There is issue of lack of PPE in Pakistan. And the top is our own safety. So if I'm not safe, how can I ensure that my family is going to be safe? You're going to go home every day to your kids, to your elderly parents. So what you're bringing home? If God forbid your parents, your children get infected because of you, are you going to be able to forgive yourself? So these are all the issues, you know, we come across every day, and, you know, every night we're having nightmares about it. And then the most important, again, sustainability of our practices. It was very easy for everybody to do lockdown, close the practices. But there are a lot of GPs who only survive on these clinical practices because that's their only job they do. So financial issues, they've closed down their clinics, they have to pay the clinic rent, they have to pay for their staff. Or even if the clinics were open, they have reduced number of patients. They had temporary closures. They have to pay extra for expenses for the PPEs and for the staff as well. So these were the challenges we were coming across. And then the final one is isolation. Because as a primary care physician, sometimes you feel that you're working lonely. You don't have that support which a hospital doctor can have. You have limited access to information. Again, evidence-based information. The hospitals are in contact. If you look at Pakistan, they are in contact with people like APPNA. They are in contact with people like from China. FHEA are trying to arrange webinars and stuff. But that private GP is working in a remote area. Is he able to access that evidence-based information? Is there any training opportunities for him? So that's the challenges they're going to face, or they are already facing, unfortunately. And then risk of burnout. So why the risk of burnout? So it's not the overwork I'm only doing. It's not the 100 calls I'm getting every day. It's the anxiety and fear I have to live with, because I might be bringing the coronavirus home to my own family, to my own kids. I'm overworked due to increased workload because it's time consuming. I'm taking history twice, I'm doing triage twice, I'm speaking to the patient on telephone, and I have to adopt my practice style. Plus, despite that, there is no recognition of my service, unfortunately. The hospital doctors, the doctors working in ICU, yes, they are our heroes. They are working frontline, but they know their enemy. The corona is, they are facing corona and the enemy is there and they are fully protected. While me as a primary care physician sitting in a far-flung area in a clinic, I'm not even sure what I'm facing. I haven't got a bulletproof jacket so the corona can hit me anywhere he wants. So that's, and there is no recognition of my service. So a lot of GPs died. Most of the time, you know, nobody even know about it. So these are all the challenges I'm going to face and you guys are already facing. But again, because I'm a GP and I specialize in awesomeness, so it's still my duty to support the patient and gain their trust. And yes, in this difficult time. So a challenge only becomes an obstacle when you go to it, and I'm not going to bow down. So whenever I'm like a lion, when I face a challenge, I will look for a way, not for a way out. So what I've thought the strategies could be, and I'm sure all the experts going to sink in that, or they will add on to it. The possible solutions could be a coordinated and integrated approach. Recently in KP, we have announced locum positions because we thought if we get more doctors, we will be able to treat patients. But them local positions were only for hospital doctors. And yet half of my hospital doctors have already been asked to close down the services. And the poor GPs who have shut down their services, so the service is not available. On the other side, I'm trying to provide essential health services in the same hospital, and yet I'm worried that there is a risk of infection. So I thought about it and I sent few messages, though I didn't get any reply from the ministers. And I thought, please recognize my service. Please recognize the service of primary care physician. Please provide them training, provide them PPE, set up a telemedicine and triage system for them, get them on locums, offer the non-COVID services in satellite small community primary care centers, and get the specialists on telemedicine for them who can advise them, and then they can treat the and manage the patient there. So that means the non-COVID patient is not going to come to the hospital and get mixed in with other patients. Also create a referral system. This is the time now we need to think that we have to develop a proper primary care systems like any other countries. I'm sure like, you know, NHS, US, they all have a proper primary care or comprehensive model. So this is the time we need to start thinking as well. Can we develop an advice line like KP has already done? And to gain the people trust, you put all these GPs, all these primary care physicians who can give advice to the patient, or give them financial and psychological support, because that's important. If you're not going to give them, if I get burnout, I'm not going to be able to treat patients. So that's why if you're going to support us, if you're going to support the primary care physician, if you're going to help them to overcome these challenges, or if you're going to look for the same solutions which they are recommending, I'm sure we will be able to provide better service. Because bear in mind, 60 to 70% patient presenting with primary care problem. And because you haven't had a comprehensive primary care system, so all of them were going to the major tertiary care hospitals, which you now want to close down because you don't want to, you want to reduce the risk of infection. So here is the time to start thinking about developing a comprehensive primary care model. So again, I will try to end it here because I'm sure I've just raised the questions. These are the challenges which I thought are important. And I'm sure most of you are likely to agree with me, or you're going to add it on. So I will end with this quote from Jim Rohn. The greatest gift you can give to somebody is your own personal development. So as a primary care physician, this is a time for us to have our own personal development plan, to develop ourselves, to get ready if God forbid a next pandemic comes. Because I used to say, if you will take care of me, I will take care of you, as every doctor says. But now in this pandemic, the situation is different. Now I say, I will take care of me for you if you will take care of you for me. So I will take care of me for you if you will take care of you for me. So I will try to end it with this. And hopefully, obviously, if there is any questions, so the panelists and I will be available as well, and inshallah, I'll be able to answer. So thank you. Thank you, Danish.
Thank you so much, Jalil. This was wonderful, very comprehensive, elaborative, and very thoughtful, thought-provoking. Before I go on to invite panelists to introduce themselves and make their comments, I'm going to take a few minutes, and I think we have the pleasure of having the president of APPNA 2020, Professor Naheed Usmani, on the call. So I'm going to just ask her if she is available to introduce herself and make any comments and to the audience. Dr. Naheed.
Assalamu alaikum, everyone. I think this is the most important topic that we have covered in the last 3 months. Primary care is like the basis of the medicine practiced in Pakistan. I would have liked to know more about the challenges of testing and screening for COVID-19. I know that APPNA is also involved in the telehealth screening process that Dr. Suhail Chughtai started, and how are the primary care physicians in Pakistan dealing with the screening question and the testing challenges. My very close friend, who is a practicing gynecologist, has sort of raised the issue to me that when she wants her pre-surgical screening for COVID-19, patients are refusing. They feel extremely emotionally overwhelmed and they don't want that screening done, which is impacting the... Dr. Jalil, love your talk, but have you noticed that resistance on the part of the patients, and how are you guys dealing with it?
Yeah, thank you very much, Dr. Naheed. Yeah, that's definitely a big challenge for us because now hospitals are refusing to take, even my own sister had to go for antenatal screening, and the hospital advised, unless she had a COVID screening, we're not going to take. So obviously she has to go. But at the moment, as I said, like, you know, patients are definitely refusing if they are not having any symptoms. And the stigma is because the main issue which we have noticed was initially when we started and the picture regarding IPC were not clear. So a big stigma created when they were doing the funeral of COVID patients. So that generated a lot of conspiracy theories. And because of that, patients are very much reluctant. However, as a primary care physician, or if you have that relation with the patient and if it's your regular patient, and if you explain to the patient in detail, they are listening and then they are going for the test. Or if they've been in contact with a positive patient, then they definitely want to have a test. We rather have another extreme when we are trying to advise patient not to have the test because everybody is calling because they want the test. And obviously we don't have that capacity up till now. A lot of private hospitals were not allowed to do testing. And yet we still haven't got a recommended screening test apart from the main PCR because we still don't accept serology as a screening test or anything. So we have both extreme. One extreme is the one when people are refusing the test, but we still have another extreme when people are demanding for the test. And now what to try to say, how we are trying to deal with it, as said, it's very difficult to answer is the telemedicine service. Yes, some people, for educated people, yes, it's easy. You try to explain and they do understand, but they still have that fear that if I come back positive, and then the stigma attached to it when the public health people and the district administration raid your house and the police corner off your street and stuff. So this is the main reason when people are refusing. So once that stigma is over, then people are to go for
Thank you,
this.
Jalil. So let me start the Q&A session by first inviting the panelists one by one to briefly introduce themselves and make any comments or additions to the topic for today, or raise any other questions. We'll go around with all the panelists and then we'll start with the formal Q&A. Let me start by inviting Dr. Tariq Aziz, the President of Pakistan Society of Family Physician and President-elect of WONCA, SAR, to please introduce yourself in some briefly and then make your comments. Dr. Tariq.
Well, I'm Dr. Tariq Aziz. I'm practicing family medicine for more than 40 years now. And I've been in the hospital also as HOD of family medicine. So I have a variety of experience. First of all, I would like to have a comment regarding the changes which we can bring in our practice, how we can avoid getting ourselves infected. First of all, as we discussed with the government of Punjab, that we should allow only one patient at a time to enter our clinic to prevent the infection between themselves, and also to educate them before they really reach my office. Secondly, we need to wear PPEs for ourselves, as I'm wearing right now, because Sunday evening is busy for me as well. So we need to protect ourselves and keep, of course, sanitizer, all these things with us. And then there's so many GPs who actually close their clinics and they have still not started the clinic as yet. And as GP has no fixed income, it is really horrible time for their families. So we need to educate our GPs that unless we clean our clinics with the bleach, we prepare our own solutions 1/9, which is very cheap. Otherwise, we can use expensive things also to clean our clinics, or every instrument we use over here. And again, we may have to bring some extra masks for our patients as well, because I have one of my guards sitting outside. He'll not allow anybody to enter my clinic without a mask, even if he's my family member. So we need to provide that mask to that particular person. We may have to provide a sanitizer at the door, and we have to educate them if we have a serious patient who is coughing and sneezing, we need to really keep a special distance from him. And for them, I've made a special space outside my office. They can sit there so that I can talk to them with a distance, and I avoid actually examining them at all, because there are so many symptoms which are quite familiar and you can diagnose them very easily. And then you can ask them to take these medications, make their temperature charts, and then let you know on telephone. Although Dr. Jalil talked about telemedicine, but still we need to educate our patients and our family physicians who are not well aware of the advantages of it and who are not used to it actually. And our patients, they also want to see the doctor in person. They will not be satisfied if you're just talking to them on the telephone. And these are the problems that you're facing. So first of all, the safety of the doctor by itself, because even one of my close friends was also an MPA in Punjab Assembly, Dr. Muzaffar Sheikh, he got coronavirus, and on top of that, he got dengue at Mayo Hospital, which is one of the best centers made by the government of Punjab. So our family physicians, couple of them at Fatima Memorial Hospital, they also got it. So we have quite a lot of mortalities among our family physicians. And we met the health minister and our steering committee in the special health unit of Punjab government. They are not prepared to provide us with any PPEs or anything at a reasonable price. So we have started contacting the people who are manufacturing these things, and I've got all these things for my staff and myself at a cheaper rate once we buy in hundreds. So we can provide to our clinicians or our friends and make a contact with somebody. This is very practical because nobody will give you a few gowns, maybe a dozen at a reasonable price. They will charge a lot of money. And most of them, they are disposable. You can't afford that. You need to have a surgical gowns which are washable, which can be washed in a particular way, not mixing with your other clothing at the home. So I suppose having a lot of masks, having your own PPEs, and GPs or family physicians, they need to spend some money on that because they can't really go away from their livelihood maybe for next year or 2 years. So to live with coronavirus is again a very technical thing. And unless we really prepare ourselves and educate our patients, while talking to your patients, my guard will stop the patient outside my clinic and give his mobile number to me. I'll talk to him and what the problems are. If they are by other patients like diabetic, hypertensive, they are very safe. They can easily come in with the mask and sanitizer. But if they have particular respiratory symptoms, then we need to be very careful and put them in a separate room, saving the other patients and myself. So I'll convey this message to all of you and my family physician in particular, because we can't leave our practice, we can't leave our livelihood. We need to spend some money. We need to have some extra attendance. We need to have some extra consulting rooms for suspected patients, and then to clean them, mop them, all these things with bleach or chlorinated liquids or fluids. So that's my first comment. Any other thing you would like to add to it?
Thank you, Dr. Tariq. So let me next go to Professor Dr. Ziaul Haq. Dr. Ziaul Haq is the Dean of Faculty of Public Health and is also the Pro Vice Chancellor for Khyber Medical University. Dr. Ziaul Haq, please introduce yourself and make your comments.
Thank you so much. I'm Dr. Zia. I'm a public health person, Dean and Pro Vice Chancellor at Khyber Medical University. The primary health is something very keen, very close to my heart, and working in the health system and now in the academics. Unfortunately, it has a very limited role as a whole in our health system. See, now in the COVID, the whole response is given by the teaching hospital. You will never ever hear the name of primary health care, the BHU and RHC, even at the Tahsil hospital or the DSQ. So it's the whole system, the politician, the people, everybody is talking about the teaching hospital. You will never hear the name of any primary health care facility. To me, I think this is the opportunity that we should grab, and we should tell if there is, what about the non-COVID health services? Where are the fewer clinics? So this is the opportunity that we as a public health person and you guys as the primary healthcare specialist, that we should convince our health authorities that let's make use of our primary health care. This is a huge setup of the primary health care. Every union council has a basic health unit, and it is very well staffed, very well trained, but unfortunately there is no accessibility issues, or mostly it's the trust issues. The people think that it's the only teaching hospital which will give us the opportunity. So there's no referral system, there is no catchment population, there is no investigation at the basic health unit. Not even a sugar can be tested, blood sugar can be tested at a one BHU. So I think this is the time that we should do something, and we should ask the healthcare people to come up with solution. At least I think it's a good opportunity to start with the fewer clinic. If you say that every union council has a fewer clinic and the people should go to the health facility, and the fewer, if they refer it to the teaching or they refer it to the lab, then it could be, I think this could be a start for us.
Thank you so much, Professor Zia. Let me move on to Dr. Unab Khan next. Dr. Unab Khan is the Associate Professor and Chairperson of Department of Family Medicine at Aga Khan University. And she has been leading the screening and testing efforts at Aga Khan and is involved with the outpatient care of COVID-19 patients, including pregnant women. Dr. Unab, if you can also make some extra comments. There is requests on talking about telemedicine in general and COVID-19, and like Nahid was talking about testing remotely or telescreening. That'll be awesome. Thank you. Please go ahead.
Sure. Thank you very much, Danish, and Assalamu alaikum, everybody. I think everybody is absolutely right. Primary care is something which has been ignored in Pakistan for a very, very long time. And this pandemic has really made us see the importance of working on it. So while we continue to work on that, I think the opportunity for us is kind of looking at tele-screening. So when we started in January, when we got our first COVID patient, it fell on the family medicine department to start the screening and testing at Khan University. And we took it up with the bang, and we were initially doing it as face-to-face. So I think in every given day, in a 24-hour time period, we were getting about 300 to 400 patients coming in. And what we've recognized is as time went on, recognizing the exposure of the primary care physicians that was happening and the risk to the staff, we recognize that we need to quickly move to tele-screening and telemedicine. The challenge of tele-screening for COVID itself has been that as the epidemiology of the disease has changed, the screening questions have to change, and we have to adapt accordingly, right? So the first day that I was asking was the question of, have you come back from China? And when you have a cough and a sore throat. And now my question is, have you been in contact with anybody with suspected COVID? So just being able to move from one step to the next has been really, really important. And recognizing that national guidelines will always lag behind a little to what you and I are seeing face to face. So, you know, as frontline physicians, I know when my questions need to change, because very quickly I was getting patients from Iran, very quickly I was getting students coming back from the US and UK. So we had to change our questions very rapidly to decide who we could send for testing, because testing PCR was precious. We didn't have enough of it at that point in time in Pakistan. Now what we moved to is we've really moved beyond tele-screening, and we moved to task shifting. I, as a physician, don't need to do those screening questions. We have trained our nurses and our frontline operators and CSRs. So it starts with somebody trying to make an appointment. They can come to a nursing helpline. The nurses are now very, very well equipped and trained to ask those screening questions. And then I, the physician, can see the patient more holistically and take care of deciding not just whether they need testing or not, but also take care of their diabetes, hypertension, and take care of all the worries that they bring with them, right? The baggage of having COVID is really, really huge. So that is one thing that we've done. We've really worked hard with the Sindh government. And right now, AKU has committed to train 10,000 medical staff in learning how to use PPE. Not every one of us needs N95 mask every time I'm seeing a patient, right? So this worry that mujhe N95 ki zarurat hai is unreal. A surgical mask can work really well in saving me and saving the patient if the patient's also wearing a mask. So as Dr. Tariq was talking about, giving masks to both sides, even surgical masks do this, but really training our medical personnel in what PPE is required at what point and in what kind of clinical encounter, inshallah, will make a huge dent. And then finally, I think what Professor Zia was talking about is really important is our job as primary care physicians is not just to take care of the non-COVID patients. To me, a big part of what I do is the risk stratification of which COVID patient actually needs to go into the hospital, right? So how do I decide which one needs to go? Even if I'm doing it as a telemedicine and the teleclinic, what is it that I'm looking in the nuances in the way, because sometimes I can't get them on Zoom. I'm not having any visual encounter with the patient. Sometimes it really is over the phone. So how do I pick, is this patient getting a little too breathless? Even in completing a sentence. Is this a patient who already has diabetes, who already has cardiac disease? Is this somebody who's going to be high risk because of that? So really being able to risk stratify using whatever is available to us has become really important. We moved to telemedicine. We are doing a lot of face-to-face encounters also for our COVID suspect patients. And that is because you're right. We are Pakistan. Our patients have never been used to telemedicine. They need that touch. They need that face-to-face encounter. And if that face-to-face encounter, when I'm feeling safe and I have the right PPE and I can give them that comfort that it's going to be okay to do a test, or maybe that you don't need to do a test, goes a long, long way. So I'll stop there because I know I have other colleagues, but I think these are really important things that Dr. Jalil brought up.
Thank you so much, Dr. Unab. So let me invite Dr. Hisham Haq next. Dr. Hisham is a primary care provider in UK, a GP partner, LMC treasurer, and also secretary for APPNA. Please, Hisham, go ahead.
Thank you very much for inviting me to be one of the panel members today. APPNA has done quite a lot of work in Pakistan with the National Incubation Hub, and we have looked at multiple sort of like technology solutions to implement and I've been a panelist in one of those while we were evaluating a lot of these technologies. So there are a lot of solutions out there as well. The implementation phase is where things are lacking, but there is no dearth of ideas and practical solutions which are out there. We have got colleagues who have developed TBEs and are now in the process of developing respirators as well, and manufacturing them quite indigenously in Pakistan and bringing them up to standards, ISO 9000 standards, which are there for industrial manufacture. So I know for a fact that there is a lot of work which is being done in Pakistan. The problem seems to be the fact that the healthcare does not require just us as medics delivering the solutions in the front line. We are there, but soldiers are only as good as the equipment you give them. And I think what we need to talk about is looking at the IT solutions which are available as well. I know some of the Q&A members have also asked about IT solutions and whether people can have mobile records, whether those records can actually be verifiable, how they can actually be moved ahead. And I think where APPNI and APPNA are working quite closely with the governments, I think this is one of our responsibilities to talk about the IT solutions and the backbone of the healthcare structure, because without a backbone of healthcare in the healthcare structure, without making sure that we can capitalize on the 4G and the 5G revolution, which we are being promised, we are not going to get too far in terms of taking healthcare to where it's actually needed, which is away from the big tertiary centers in the big cities and actually taking them right back to the back quarters of our borders. So there is a lot of work which needs to be done. I think APPNA Merit program by itself, with us collaborating with colleagues in Pakistan as well, I think we're on a journey as such. It's not going to be any quick fixes or any quick solutions out there. And it is a multi-dimensional problem. It's a big beast that we're going to have to tackle in many different ways, which is going to require a collective effort on all our parts. But this is a journey, and I'm quite sure that we're over there with colleagues such as Professor Zia, Dr. Tariq, and Unab as well. So I think that there is a lot of work to be done. Thank you.
Thank you, Hisham. So I'm going to start with questions. I have a lot of questions and I don't think we can cover everything here. So I'm going to try to prioritize it this way. I'll try to address the questions by the attendees on this webinar first. I will also try to then address questions that are most relevant to today's topic that were submitted on the COVID webinars. And then if we still have time, we'll look at some other questions. I will put the question to the speaker, Dr. Abdul Jalil Khan. And then afterwards, any of the panelists can add additional comments as per their interest, or Dr. Jalil can just direct it to one of the panelists as per his discretion. So the first question I'm going to begin with is from one of our participants today, Dr. Iftikhar Ijaz. Dr. Iftikhar Ijaz is the professor of pediatrics at King Edward Medical University. And after thanking the panelists, his question is regarding testing doctors involved in care of COVID-19 patients, screening as a routine. In this circumstances, although it's an additional cost, is this needed? Shall this be done? Or should we do PCR versus serology testing? And what should be the suggestion to the government for physicians taking care of patients with COVID-19 infection in those wards? Dr. Jalil?
Thank you very much, guys. So very important questions. And a lot of healthcare professionals are actually asking. So for Professor Ijazi, asked the right question because, so if you look at it, a screening, at the moment, WHO doesn't recommend any serology testing. However, in UK, Hisham will be able to further enlighten this. In UK, they are talking about bringing some serology testing by a company which is yet to be developed yet. And they are thinking of considering doing screening of all of their doctors. In Pakistan, yes, looking at the rate of doctors getting infected, or the healthcare professional, I would say, getting infected, it was going to be wise to actually start doing the screening. But as I said, like, is PCR going to be costly? Yes, it's going to be costly. But if that's going to encourage, at least that will do two things. One, it will just make people a bit more apprehensive, and they're going to start doing more strict IPC measures, because there is a bit of part of weakness from our side as well as the healthcare professions. So plus it will give you that assurance, like when you're going back to your family. So I will suggest Hisham to answer this, what UK is planning to do at the moment.
So the experience in the UK has been that testing, when it was initially introduced, was quite slow. We only had about 5,000 tests. And from 5,000, it was ramped up to about 7,500 to 8,000 to 10,000. It's currently running at somewhere around about 100,000 tests that they are doing every year. Now, even in a system which is not resource constrained, the number of tests and the numbers are actually, they don't tell the whole story. The whole story is that the PCR testing, or the more accurate sort of testing, which with sort of like throat swabs, those sort of tests are still numbering in the tens of thousands. So the antigen testing is now being introduced. The antigen testing is still out there. The system, there is a big backlog. There was an article recently in the Health Services Journal which talked about a lot of testing which was being contracted out, not actually getting actually tested, and a lot of delays in the samples, and a lot of samples getting lost along the way as well. So the picture, even in the UK, seems to be fairly bleak, and our number of cases are quite high per million population as such. So centrally, the testing has also been centralized. So we've got a central portal where we, as primary care physicians, don't actually have access to all the tests. Anyone who needs a test, who is identified on the symptoms, gets through a screening telephone line, and after the screening telephone line, they then go ahead and then they book the tests. The big problem that we have had has been care homes. So the majority of the deaths that we are having are in the more vulnerable population segment, people with multiple comorbidities, increasing age, and that then necessitated increasing the testing, or increasing the number of tests which are available, mainly to the people who were looking after the care homes, or the care home staff as well. Doctors also have been infected. A lot of my colleagues have had very, very close brushes, and it's shaken us to the core when you're seeing someone next to you fall down. And very recently, a colleague of mine who is a COVID lead in one of the local trusts working in the intensive care unit, and someone who teaches people how to don on and doff off, actually managed to get infected as well. So this is a condition which is quite severe. It goes through various sort of strains. But testing-wise, the testing is available. It is available on request. It is available on pre-bookable appointments. And even testing over here is quite limited. So the testing back home is actually going to be even more restrained. And unless we introduce testing only for the clinically significant. So the whole challenge is that if someone is being tested, what are you testing for? Is it going to change your management? If you have got symptoms, if they are mild, and if you're fearful, if we're just treating the fear, then the whole nation is fearful. I'm fearful if I would be in that sort of environment. But the best that you can do is you have to sort of like rationalize the tests according to the needs that we have. And that's what we're trying to do over here. Unab mentioned quite nicely that the fact that not everyone needs an N95. And if we try to go for N95 masks, we won't have any masks left out there as well. I know people are wearing respirators which have got higher thresholds in terms of particulate filters, but
thank you, Sham. Sorry, for the sake of time, because I have a lot of questions, I'm gonna keep moving. Any
Ganesh,
other panelists have any?
Can I just add something? So we've been struggling with this whole concept of should we be testing each one of us and the 5,000 clinical personnel at the hospital. And you know, both the CDC, the WHO, everybody will say that PCR will always remain the first test of choice until the antigen tests become more widely available. I think I want to caution people about getting serology and the antibody test because we all know that the antibody tests right now are also cross-reactive. There isn't one out there which is going to be purely just for SARS-CoV-19. And so, you know, just this false sense of security that people are getting after getting an antibody and saying, oh, I'm safe and now I'm fine and I don't have to wear PPE. I don't want our physicians and our family physicians to kind of have that false sense of security. So a PCR as well. What we've done at AKU is we now have an app. So every clinician, every person who walks into the hospital every day has to make sure that they are clearing themselves up on the app. So, you know, it asks 4 questions and it'll ask if you've been exposed to somebody when you were not wearing PPE. And if you get a red mark, that means that either because of your symptoms or because of your exposure, you are somebody who needs to be evaluated and then get tested with a PCR. If you are in the clear, then that's fine. So we've kind of tried to come up with some innovative ways of doing it.
Thank you, Dr. Nav. I think this idea is well worth noting about some kind of a screening to the primary care providers or even physicians in the hospital. Next question, again from one of the attendees, another very important topic, and I think that will be very prudent for Dr. Jalil and also for Dr. Tariq Aziz. The question is from Dr. Zainab Muhammad. how do you think that the lack of trust or denial in community can be addressed, which is one of the big challenges? And how can we have role of primary care providers in this challenge about people, not denying this as a reality and accepting it? Dr. Jalil, why don't you go first, and we'll invite Dr. Tariq next.
Yeah, we'll keep it short because of the time. Yeah, but yes, you already mentioned about media. Media has a role. Politician has a role. In our culture, especially in KP, the religious leader role come here. Rather than, we all need to be on board. They need to sit together and they need to come up with a solution. And the government has already started. Professor Zia, myself, a lot of our the government asked us to do some short clips, videos, introductory, on social media. But the most important is, again, if it comes from the local leaders, the local community, so that will have more impact. And media, of course, yes.
Dr. Tariq?
Yeah, as a family physician, I suppose we have a very important role in educating families, because as I'm treating the third generation now, if I can tell a family member, a senior member, that this is a fact and you need to educate your younger ones or your family members, it is very effective, I must tell you, because the people when they are just kids in their KG classes, now they are married and have their own children. So you have a very long association with them. And your word to a family from that point of view is very effective. So I suppose while we are teaching or treating our patients, we can continue with the health education, because that is the most potent and most effective time when a patient is coming to you. When he is ill, he is most receptive. So I suppose we owe a big job on our hands, that we need to educate our patients and their families to the extent we can do it. We need to spend some time with them. We have to do something regarding some charts or something just outside your office where they can read about all these things, and they can come to you mentally prepared. And once they are at a certain level, you can really build them up. So I suppose the family physicians, they can bring all those people who are in denial to be more realistic, and their role is something more important as compared to the hospital or ward doctors. So this is basically our role, how to educate our patients, and we can do it very effectively. I must tell you, because your one word as a family physician is much more effective as compared to any other doctor whom you see once in your lifetime in a hospital or OPD. So I think that's a very important point. Family physician is the best person. We need to devise methods and means of some charts outside the clinic in the waiting area, and some education material there, and especially our assistants. I have trained them and they are very helpful in providing them with the masks, the sanitizers, educating them. And sometimes these people, they are not so helpful, but the rest I can do is, in the end, perhaps I can really polish all that education given by my assistants, and I have found them very, very effective. And even the media has done a lot of job.
That's wonderful. And I agree, using assistants and other people trained around you could be very useful. Next question from one of the attendees. I think it will be a very good question also for Professor Zia. And after Dr. Jalil, I think Professor Zia can add comment to it. It's from Dr. Iqbal Muhammad. And he's talking about, where there are settings where there are challenges not having extra rooms or space to create what Dr. Tariq have done to have patients in additional room who are having fever or sore throat. So what are kind of your suggestions or guidelines to your primary care physicians right now on personal protective equipment? What should they do? What kind of things they can do for their room cleanliness and septic techniques and things like that for those limited situations? Dr. Jalil?
Yeah, thank you very much. So for that, obviously, as I mentioned, the IPC training, definitely we need to require that. A lot of our physicians, obviously they need more cleaning and disinfection of their clinics. And that's what we need to do training. And as I said, KMU and WHO all started a lot of IPC trainings, and the health department is currently doing it as well. Which we have recruited a special triage system, which means even everybody in the village have a mobile phone. So you can put like a board or thing before you walk in straight away, can you call in? Or you can just ask one of your attendees who can the patient just in front of your clinic, but keep a 6 foot or minimum 1 meter distance, and just ask 1 or 2 screening questions that why the patient is here. if the patient is here any kind of upper respiratory tract symptoms, then he should have been, you can ask them to give a mask, or you can even, the CDC is now asking people to, whenever they go out, they should have a mask. So that's now the recommendation in Pakistan. So before coming to the clinic, you can put posters, you can put a chart, and then you only let the patient in once the first 2 screening questions is being done. That can be easily translated in Urdu Pashto for your attendant and clinic. A lot of the time, appointments are made by telephone. So when people are calling, you can do that, or you can put some appointment slots like from 8 o'clock. A lot of private clinics don't run much in the morning. So if you put that time for people related to respiratory symptoms, and then you properly disinfect the clinic, and then you see the rest afterward. So you need to do some kind of changes. You know, you can't just completely presume, and you need to ensure there is a distance. So whether it's outside, whether in the clinic. From public health perspective, I would see what's Professor Zia take on this as well. So let's see what he suggests.
Dr. Zia.
Yeah, I think the SOPs already been developed, and these SOPs are given to the owner of these private facilities here in KP and other provinces as well. This is one side is you have to educate yourself. You know, the PPEs, if you are there, we are not used to the common precautionary measures the physician here in our part of the world. We don't, to be honest, we don't practice the safe practices here. So we need to bring those safe practices into our real practice here. So the first thing is you have to bring change in your own self. You have to treat every patient as a COVID positive patient. You cannot, the triage is good, but you know the PCR, you know the sensitivity, and then the asymptomatic patient, and then in the culture here, as you said, nobody said that I have the COVID. We have seen people who are COVID positive test, but they are not telling people that we are COVID positive. So in these circumstances, I think they should take every patient as COVID positive. And then what Dr. Tariq said, that the role of the assistant, not yourself, but your assistant role, how you have educated them and how the people are coming to there. But the written SOPs are there. I think you need to start your clinic. This is very important because you are losing people to the COVID. We are losing people equally or maybe more than that to not COVID conditions. So you need to come up, but if you, and the guidelines, the SOPs are there. If you adopt it, I always gave the example of the Wuhan. So when there were the healthcare workers from the Wuhan, they were 5 to 10% of them infected. But those 44,000 of the healthcare worker who went to help them from the Beijing and other year, and none of them were infected because they followed those SOPs.
Thank you so much. And if you could also make a quick comment, Dr. Zia, given that you're the dean, there's a specific question about any guidelines to medical students. Have you done anything specific on how to reduce the risk of those students in training to be physicians?
Yeah, at the moment, we are only focusing on online courses. The schools are no more functional, but we are in this phase that in July and 15th of July, after that, we have to start it because you can't lose the whole session. So yes, we are working on that.
Thank you. And then I think a very important and prudent question, and I would put it to all the panelists to add to it, their brief comment after the speaker, is a question about the mental state or health of common man. This is something that has been addressed as an issue in physicians, but are we seeing stress or anxiety or issues or challenges in people with or without prior mental health issues in the primary care setting, Dr. Jalil?
Certainly we do, because you know it's very common with any pandemic, and people are living fear and anxiety, and especially if they're not aware and they don't have access to that information which is factual. So it's 2 ways of dealing with it. Definitely, as a family physician, the role comes. You have to you should screen, just like we do it in chronic disease now. If we get any diabetes patient, hypertension patient, we always screen for depression and things like that. So the same we should do now. If somebody gets positive with COVID, or if they have a close contact with positive, we should screen. And I've seen a lot of patients who later on came back negative, but because of the anxiety and the panic, they had that attack. So it is quite common. Plus, the second important is people who have death in the family from corona. So they are coming with a lot of PTSD issues and stuff like that. And that will be, even once the corona is over, that will be something like, we have to deal with. That's why, as a family physician, you need to be very vigilant. You need to be always screen. It's very important.
Dr. Unab, what's your experience, Khan?
So seeing a lot of anxiety, I think it's because of two things. Number one is the uncertainty of what is going to happen. And number two is there's no end to this, right? So people have been in lockdown for more than 6 weeks in Karachi, and people live in small houses. Structures of going to school have gone down. So, the kids are up the whole night, they're sleeping the whole morning. And so this whole anxiety cycle, the sleep hygiene has really become worse. I'm seeing a lot of pregnant women who are concerned about bringing their new child into this world of COVID, and doing a lot of counseling for that. I think one of the things that I've realized is really important is to talk about the elephant in the room. So whether I'm doing a teleconsult with a COVID positive patient, or whether I'm seeing a patient face to face for anything else, I say, how are you coping with it? This must be very anxiety provoking. And just my saying that it is a problem and it is normal for you to feel this way allows my patient to kind of open up and bring up their fears and anxiety. And a lot of them are myths. So, then you can help them in kind of dealing with the myths, and helping them there. One more thing that we are seeing is because patients who have lost their loved ones who were in the hospital, who didn't get a chance to really say goodbye to them, because they were in a COVID unit and they couldn't go in there to hug them or to say their Khudafiz. That has been really tough. So we are trying in the hospital that at least trying to FaceTime or do something so that people can say their goodbyes in person, even though it's not in person. But these are tough times. These are tough times for all of us, and I think our patients are really suffering because of it too.
Can I add something to it?
Ji, Dr. Tariq, please.
First of all, these class of patients, they need special attention as well. I have a big group of patients who don't like to come to the clinic right now because of COVID. And what they ask for is that they would like to have a sort of teleconference with them, talking to them and their families. They would like to pay the fee only for the telemedicine session, and they want it very frequently. Some of my patients even talk to me 6 times a day, which becomes a bit of headache for me, but still you need to tend to them because their worries are not really solved at all, and they have continuously locked themselves at their homes, more so in their bedrooms. So sometimes I have to visit those patients, taking a special call to them with my kit on, and then talk to them, and most of the time talking to their families. So there's certain people who are already very anxious people. You need to give them a lot of anti-anxiety medicines. You need to talk to them for maybe more than half an hour as a family physician, and that brings some change. But I suppose this scenario may persist, and handling such patients for a family physician may be really difficult, because we need to train ourselves and develop some sort of special timings for them when they can call you at liberty, or you can call them back, or you can just do some lot of messaging to them, because they have so many queries that you can't really solve them in one particular session that may be more than half an hour. So these particular patients, they form a big chunk of your patients. They're more than 30 or 40% of your clinical patients. And these particular patients, they may be very sensitive. You need to develop certain means and modes of treatment for these patients, because their doses have increased significantly since the advent of COVID. So, and their families, they have become patients as well. So taking care of such a patient, the family has really very serious problems, because they have stopped going out of the house, they've stopped going to the office, they've stopped going to the job, and that has created problem. And this may last for maybe a year or two, and this 1/3 of my clinical patients is causing real problems. I suppose the family physician again has a very important role. If you have to go to visit their families, that's the only way, because they will never come to your clinic. They'll say they'll get the COVID when they are with me over here. So we need to advise. I'll talk to other people over here also, Dr. Naheed also, that we should work on this and try to form some sort of SOPs for them as well, so that way we can help them, because this is not a small chunk. At least 1/3 to 40% of your patients, they are having such problems. And this is something very important aspect we need to address, especially family physician can do that. Thank you.
Thank you so much, Dr. Tariq Aziz. So I think we are significantly over time, and I'm going to start concluding here pretty soon in a few minutes. I want to say that we probably need another hour of a webinar just to answer all the questions that I have. Over 30 questions are still on the list, and each one important things like sterilization and whatnot. So I think I would love to invite you again, Jalil, to come back as a speaker and maybe a panelist to answer some of these questions for us. And I would love to see every single panelist as a speaker on their own for their own webinars. Especially, I'm going to take this opportunity and ask Dr. Unab to commit on doing a session on telemedicine and assessing patients on telemedicine, which is a pretty unusual and new thing for many primary care providers because they've not done that before. And we would love to do that session with you. If you are agreeable, our coordinator will reach out to you to get a time from you, Dr. Unab.
Sure, I'd be happy to.
Thank you. It'll be a pleasure. And Dr. Tariq.
We can do IPC. IPC we can do.
Okay, wonderful. That'll be great. And Dr. Tariq, if you can be a speaker for us and do a session and maybe address some of these challenges, that will be really good for us too.
Okay, I'll do that.
So I invite our president of APPNA, Professor Naheed Usmani, to say a vote of thanks and make her comment so we can officially conclude this session for today. Professor Naheed.
Ji, Assalamu alaikum. I think this was an amazing session, and it raised, I think the sign of a successful conference is that it raises more questions than it answers. It makes people think, and that's what today's session did. I would like to thank all the panelists and Dr. Jalil Khan for a very eloquent and important discussion that happened. I was just sharing the UMass, where I work, proposed sort of performer for physicians and nurses and researchers and administrative staff returning to the hospital, at least partially. And we have always seen patients with proper PPEs, which include surgical masks, gowns, and goggles if we were suspecting COVID, and then N95 for confirmed COVID cases. We have an online self-report tool that we have to fill whether we are working or not working, that the hospital system is tracking to see if any one of us is developing symptoms, and those specific people get tested very rapidly to see if with the PCR. So, and then as the medical school is opening gradually, they are testing all returning employees for COVID. And so that the healthcare workers, we have a very clear idea. We can wrap our head around what is the impact of the disease. The reality is that more healthcare workers have gotten infected with COVID. So we have to heal ourselves and protect ourselves. I think as primary care, that is a huge duty of every single physician, that we have to protect ourselves. And it's appropriate that we do test ourselves if they are concerning symptoms. And perhaps a methodology adopted as an AKU needs to develop for the whole country, where the physicians, I'm seeing so many physician deaths in all different institutions, from Islamabad, Peshawar, to Karachi, to Sindh, to Multan. We know that physicians are more affected in Pakistan, but the same is true here. And we need to focus on how we can protect ourselves, not by not doing our duties, but appropriate testing and protection. I think that's the bottom line. Thank you, everyone. This has been wonderful. I hope this dialogue continues because a lot of work needs to be done. Thank you, Dr. Danish Bhatti and Dr. Shahid Rafiq for putting these wonderful webinars together.
Thank you so much, Dr. Naeem Usmani. Thank you all the panelists and especially our speaker, Dr. Jalil Khan, for putting all this together and inviting everyone. We would love to see you soon and we'll be reaching out to you. Thank you, everyone. Have a nice day.
Thank you. Khuda Hafiz.
Allah Hafiz.
Hafiz.
Bye-bye.
Allah Hafiz.
Thank you.